Good afternoon. My name is Professor Colin Palmer from the University of Dundee. I'm wanting to talk to you today about work we've been looking at in terms of using genomics for precision medicine in type 2 diabetes. So we know that diabetes is a very complex disease, and therefore we wouldn't expect everybody to respond to the same treatments or to have the same kind of diabetes. And genetically, we know that rare versions of diabetes, where the genetics mutation is in different parts of the glucose sensing mechanism, such as in the sulfonylurea pump, KIR6.2 and SIRP1. We know that individuals who have got mutations here, who normally would be treated with as type 1 diabetics, because they have no apparent insulin secretion. But we found that based on the genetics, that these individuals will actually respond really well to sulfonylureas, and as soon as you treat these people with sulfonylureas, they start making insulin, and their diabetes is essentially cured. We also know that common diabetes, which is type 2 diabetes, is actually a complex disease. It is not just one consistent phenotype. And in Sweden, it's been shown that basically you can cluster type 2 diabetes into 5 different types of diabetes. And based on how well their beta cells function, how much insulin resistance, how obese individuals are, and these people have very different outcomes for diabetes, and potentially respond differently to different drugs. And this is an illustration of looking at these different types of diabetes and how the different outcomes. In this case, it's looking at kidney diseases and eye diseases, and we can see that on the left here that some of the different types of diabetes have very increased amounts of kidney disease. And so really the different vascular complications are very different by these different diabetes subgroups. Now, why do we have these different diabetes subgroups? Well, one of the reasons is that with many genes. We now know hundreds of different genes which all contribute to your risk for type 2 diabetes. And what we can actually do is we can actually see that these all affect different mechanisms of how the diabetes occurs. And you can see that different genes affect different functionalities. So some affect insulin action, some affect insulin secretion, some affect how much adiposity you have, and some also affect your lipid metabolism. So this is really, this means that you can actually define genetically what cluster and what type and what flavor of type 2 diabetes you have using genetics. Now you think, well, how do we look? It sounds awfully complicated to look at all these hundreds and hundreds of different genes, but actually it's very simple. These days it's really easy to do that. And what we basically use microchips, which are extremely inexpensive tests, which basically we can do millions of tests across individuals for £25, which and that's less than the cost for many of the clinical tests that might be done many times. So this is a very affordable and very powerful test that is available now. And obviously we're interested in how these genetics varies across different populations, where type 2 diabetes is very different. So that all of those clusters that have been defined so far are all based on white Caucasian populations. But it's very clear that, say, the difference between Scotland and India, type 2 diabetes is very, very different. In India, the age of onset of type 2 diabetes is incredibly low, much, much lower than we see in Scotland. And if we look at the genetics of South Asians, we can see that we can separate out different subgroups of South Asians. Obviously, the Caucasian genetics isn't even on this graph. This is really just focusing in on how you can actually spot the different subgroups within the South Asian populations. And obviously, East Asian populations would be off this graph as well in terms of how different they are. And so the question we're really interested in is how can we actually, are these differences in the genomes affecting the types of diabetes and how the characteristics of the diabetes in these groups. So one thing we've looked at is we've said that in South Asia, the age of onset of type 2 diabetes is much, much lower. So the first thing we've been looking at is what is the genetics of age of onset within the South Asian? What genes are causing South Asians to have a lower age of onset of type 2 diabetes? And we've looked in a cohort of nearly 6,000 patients, and we've actually found some genes which are associated with age of onset within the Asian population. And these genes are actually genes that we already know about. These are genes that affect diabetes globally, but in particular in South Asian populations, they appear to be specifically affecting age of onset within the Indian populations. And another aspect which is very characteristic of South Asian diabetes is the fact that it's characterized by having extremely low HDL. So we've been interested in how genetically the South Asians have low HDL and how that's affecting their cardiovascular risk, but also their diabetes risk. And what we've found, interestingly, if we look at Indians, where we see how well they respond to lipid modulating drugs such as statins, we actually can find that in Scotland, we get quite a very healthy increase in HDL upon giving after treatment. But in the Indian population, we're actually finding that the HDL changes are really resistant to the current drug treatments for changes. Whereas if we look at LDL-C in the Indian population and the Scottish population, they respond exactly the same. So there's something genetically about the South Asian population which means that they are resistant to changes of HDL. So that's an opportunity for us to look at how a novel therapy where it's clear that our current therapies are not actually working well in terms of making the good cholesterol. So that really suggests that a new treatment is required in the Indian population to take that forward and to protect from the cardiovascular effects of the type 2 diabetes. So that's just a couple of examples of how we're using genetics to change treatment within diabetes and the potential for how it can be used across different countries and different ethnicities to learn about what's different about the different populations and how it should impact on their treatments. And really, it's an illustration of how in the future a lot of drug treatments will be guided by DNA-based information. And with that, I'd like to finish off and thank you very much for listening.